Hi everybody, welcome to Dr. Manny's YouTube Learn Shops. This is part 5, System Components for Veno-venous extracorporeal membrane oxygenation. Now the learning objectives for the session are to review ECMO components, and again I'll be using examples from the Cardio Help. Not that I'm promoting Cardio Help market at all here, it's just that this is the system that I'm familiar with here, but they're generic to most of the other ECMO units. We'll be looking at some of the safety features, the monitoring elements, and overall looking at the circuit. Okay, when we look at the ECMO components, first of all we have to have a certified practitioner. They have to be credentialed. They've got to be diligent, pay attention to detail, constantly monitor the patient and the ECMO circuit. And if there are any problems, they should be able to troubleshoot effectively or at least escalate it to a higher source. Now, when it comes to the ECMO cannula, there are just simple rules. Common sense, really. The larger the sized cannula, the less problems that you have for best practice. Small sized cannulas typically can be problematic because extracting blood may be problematic. There's more resistance to flow, thrombogenesis can occur, there could be hemolysis, there's increased afterload, and the circuit could potentially rupture. The cannula listed typically in French, 21 French for the external diameter, and looking at certain numbers that indicate the cannula flow, pressure, characteristics, which is length, internal diameter, and side hole placement. Gives you information. But these are typically things that the physician or the intensivist will be aware of. Tubing is important as well. As in most critical care, the longer the tubing, the more problems that you have. So simple rules with VV ECMO are short tubing, a short circuit is better for best practice. Long tubing in the circuit can potentially be problematic. There's more resistance to flow. You can promote thrombogenesis. There's a greater surface area for heat loss. There's greater surface contact with blood, which promotes inflammatory mediators, which can initiate ARDS. There's a greater surface area contact, which activates platelets. There's more prime volume required, which results in hemodilation and potential patient overload in the circulation. You will probably require more connections, which creates flow turbulence, hemogenesis. You may also get kinking and obstructing more easily with more tubing. So one of the primary focuses that we have with the VV ECMO tubing is to reduce thrombogenesis, which can be reduced by using an albumin prime, which provides a protein coating, hemodilution of circulating blood volume, and heparin impregnated biocoating. An important component of the VV ECMO circuit is also a bladder controller, and most circuits have it these days. It prevents extreme negative pressures in the ECMO circuit. So if you look at the diagram, the dotted circle line highlights the bladder controller. The bladder controller is in between the access pressure and the monitoring component for the SVO turn, prior to the blood pump. Now, as I said, the bladder controller prevents extreme negative pressures in the ECMO circuit because negative access pressures cause the bladder to collapse. It activates an alarm. The pump stops because you don't want extreme negative pressures in the circuit. Then the bladder slowly refills if the problem's been corrected and flow recommences. It's an important safety device. Then we've got the VV ECMO pumps, which we've looked at briefly. And these pumps act as artificial lungs, and they're used when all other medical options have failed for patients whose lungs can't provide enough oxygen or excrete carbon dioxide, as with ARDS. Now, as I mentioned, the Cardio Help isn't being promoted here. It's just one that I've used in the past, and I found very, very effective, and I have data on it. Now the Cardio Help is a compact support system suitable for VV ECMO for pulmonary support in patients with ARDS, as I've mentioned previously. And it's very, very user-friendly. There's the oxygen exchanger. But most pumps today are very, very user-friendly, not just the market Cardio Help. But from my career perspectives, it's a very important, friendly, helpful, effective pump. Now, it's also centrifugal, which means there's a low risk of extreme pressures and the causing of cavitation, which basically means extracting air out of the blood, causing a potential air embolism. Possible afterload problems could occur. The pump could heat, which can promote hemolysis, but this can happen in all pumps as a result of malfunction or ineffective switches. When it comes to the gas exchanger, the extracorporeal gas exchange is with a membrane oxygenator. Venous blood is drained from the right atrium and the vena cava, as we've indicated previously with the cannulas. So this is blood that is low in oxygen. SvO2 is low. The blood is pumped through a membrane oxygenator where it is oxygenated and CO2 is removed. Then the blood is returned to the patient. That's the function of the VV ECMO gas exchanger. Oxygen inflow, deoxygenated blood goes in, blue port, reoxygenated blood comes out, red port, from the gas exchanger, or the membrane gas exchanger, or the diffuser, whatever terminology you choose to use. Now, the gas membrane exchanger is similar to human lungs, and it's more efficient for CO2 removal than oxygen delivery, which basically means it's really good at getting rid of carbon dioxide, extracorporeal carbon dioxide removal. However, oxygen delivery is less efficient in comparison to CO2 removal. So, how does the gas membrane exchanger actually work? Simply, it's this. You've got the blood side and you've got the oxygen side, which is similar to your blood side capillaries in the lungs and your alveoli, oxygen side, in the lungs as well. So when you get oxygen going in, look at the oxygen inflow. There's no carbon dioxide presently going in. The oxygen's going in clean. So there's no CO2. As it moves through, it accumulates carbon dioxide, more carbon dioxide, high carbon dioxide, and the outflow is high in carbon dioxide. On the opposite side of the membrane, on the blood side, you've got blood inflow, which is low in oxygen and high in carbon dioxide. As it goes through, the oxygen is lower, more oxygen, so outflow is higher, carbon dioxide is lower. When you look at the membrane in between, you can see the exchange. Oxygen goes into the blood, carbon dioxide goes out, and it's constantly exchanged. That's basically how the diffuser works. Blood inflow, low in oxygen, high in carbon dioxide. Blood is desaturated when it goes in. It's low in oxygen. As the blood inflow goes in, oxygen, there's no carbon dioxide in the oxygen, so therefore no CO2. As it moves through, it accumulates carbon dioxide. More oxygen is delivered to the blood, more CO2 is removed from the blood. More oxygen is delivered to the blood, more CO2 is removed from the blood. Blood is resaturated, the outflow is higher in oxygen and lower in carbon dioxide. The outflow is high in carbon dioxide. When we look at the gas membrane exchanger, there are potential problems that could occur. Membrane collapse, condensation, embolic events. Membrane collapse basically means the membrane isn't working efficiently, and if you compare it to your lungs, it's like atelectasis. Atelectasis is lung collapse. You can also compare it to alveolar edema, condensation. And this is typically where the flow of the sweep gas is too slow. And because it's too slow going through the exchanger, it gets wet. So the saturation post-oxygenator is high in CO2. There's been inefficient gas exchange. Then you've got embolic events like adsorption. And this is basically where things get stuck, adsorbed onto the filter or the diffuser or the exchangers, and as a consequence of that, surface area is lost. And what happens is the saturation post-oxygenator demonstrates low oxygen, high CO2. It hasn't been efficient. So pre and post membrane pressures are typically high, and the transmembrane pressure, which you'll be monitoring, if it's your responsibility, will be greater than 60 millimeters of mercury. Then we have the V-V ECMO gas blender. And the gas blender is responsible for delivering oxygen in litres per minute at an FiO2 between 21% or 0.21 to 100% or 1.0. That's the market, CardioHelp, gas blender, but they're all similar depending on the company that you look at. When you look at the heat exchanger, this heats water outside a coil, and the temperature range is typically 37 to 42 degrees centigrade. Blood goes through a coil and is heated. You can have two water levels which are set, the set temperature and the actual temperature. So you can set the temperature and you can measure what the actual temperature is in the V-V ECMO heat exchanger Marquette system. It also measures the arterial and the venous. Now remember, there is no arterial. So it's the access and the return temperatures of the blood. It's measuring how warm the blood is coming out, and it's measuring how warm the blood will be sent back to the patient. Now, there's also something called the safety bridge, and it's highlighted there in blue. Now, most ECMO circuits include a bridge, and this is a circuit of tubing connecting the proximal venous access limb of the circuit to the proximus arterial infusion limb of the circuit. And this bridge is used to recirculate blood through the circuit if the patient needs to be removed from the circuit temporarily for support, or there's an emergency situation. Patient could have arrested, so therefore the bridge can be used to recirculate blood through the circuit while the patient's being resuscitated. Or there may be a problem, for example, with the exchanger. The oxygen exchanger needs changing, so therefore blood can be recirculated while the patient is being still treated. Now the safety bridge will maintain the integrity of the circuit and allow the patients to be returned to bypass after the time passes. And this may happen, as I said, during an emergency component where changes are required, or trial off procedures. You're weaning the patient. There are other aspects related to monitoring devices. In the Marquette system, and I'm sure in other systems as well, you can monitor hemoglobin, pH, PaCO2, PVO2, PVO2. It also allows blood flow to be monitored with a clip-on ultrasonic detector, which provides high and low alarms, and it also has a bubble detector. Air, to avoid air embolism before the blood goes back to the patient. Located typically in the return line. As I said, this is a clip-on ultrasonic detector which gives you high and low alarms, but also is an air detector, infrared. Now let's review briefly the VV ECMO circuit design. You've got your ARDS patient, which could be a COVID-19 patient. You've got the access and return cannula, which is in the internal jugular. This is a bicaval dual lumen catheter. Then you've got the blood pump, which is a centrifugal pump, which causes less hemolysis compared to the previous roller pumps. Then you've got the access line, which pulls blood out at a negative pressure. This is your SVO2. This is your access pressure being measured. It's negative. Then you've got the membrane oxygenator, which has got two pressures that are being monitored, transmembrane pressures, pre and post. And it has an oxygen sensor as well. Then you've got the return, flow and air detector. You've got the heat exchanger to warm the blood back to the patient's pre-extraction temperature, so the patient doesn't become hypothermic. It's returned to the patient via the bicaval cannula. This is your SaO2. Thanks. That's the end of part 5 of VV ECMO. If you found this of any benefit, as I said to you previously, please recommend it to your colleagues. If you want to subscribe, you can. I welcome your comments or your questions. Please move on and review part 6, 7, 8 and 9 of the VV ECMO Learn Shops on YouTube with Dr. Manny. Thanks everybody. See you soon.